Currently, 1 in 6 men are diagnosed with prostate cancer during their lifetime in the United States, comprising about 250,000 people in the U.S. population. This number has actually risen over the course of time due to the introduction of a blood test called prostate-specific antigen into the screening armamentarium in the United States. It's come under some scrutiny lately because of studies which early results have suggested only benefiting 1 life saved for every 1,000 men screened. But in fact, there is more follow-up now suggesting that that number might be closer to 1 in 300 or 400. And that's the number of men screened. The number of men you actually need to treat to save a life, screening with PSA, is closer to 1 in 12 to 15. Very, very close to what we have for mammography and colonoscopy. So the current screening recommendations that I tell people to think about with regard to prostate cancer is to have a baseline PSA at the age of 35, again at 40, and then every year thereafter, particularly if they're in a high-risk population. That is, men who have a family history of prostate cancer in either dad, a brother, essentially a first-degree relative, or who are African American, Hispanic, or Latino, because these populations are at much higher risk for getting aggressive disease, and therefore screening and catching it earlier can lead to higher cure rates. So once you are screened and your PSA is elevated, considered above 4 if you're over the age of 60, but if it's above 2.5 and you're between the ages of 40 and 60, you also would be considered for the next step, which is a biopsy. 12 samples are taken, 6 from the right, 6 from the left, and then they're examined by a pathologist to look for whether prostate cancer is present or not. If prostate cancer is diagnosed, it's then stratified into risk categories. There are 3 risk categories: low, intermediate, and high. Low-risk prostate cancer currently is not often treated unless a man is younger and in excellent health. So for a man in his 40s or 50s or 60s who's in good health, low-risk prostate cancer would still be considered for definitive treatment, either surgical removal or implantation of radioactive seeds, or external beam radiation, which is delivered from the outside in. These treatments are all considered standards, but in men with low-risk prostate cancer who are not in good health, particularly if they've had a heart attack or if they've had a stroke or congestive heart failure, if they're on dialysis, the reason why we consider watching those men as opposed to treating them right away is simply because in those men it takes 10 to 15 years for the prostate cancer, if it's low risk, to progress to a point where it could actually cause symptoms. And if they have a life expectancy due to other health issues that is less than that, then watching is best. The other risk groups, intermediate and high risk, is exactly what I'm talking about. These are the cancers that need treatment and need it urgently, because these are the cancers. Intermediate risk can progress in a 5 to 10 year window, high risk in less than 5 years, to a point where the person actually has symptoms and their quality of life is taken down as a result. One of the novel things that's currently being done at the Brigham Women's Hospital for these men is something called a multiparametric MRI. This is a very sophisticated staging study which not only can tell if prostate cancer is likely to be present or not, but how aggressive it is. Something called diffusion weighted imaging, which is really something that's only been discovered in the last few years, can be used on this scan to tell us if this man with low-risk prostate cancer really is low risk, or was something actually missed. Was there some higher grade cancer that the needle, the 12-core needle biopsy, missed? And so before we put somebody on surveillance, and we don't recommend treatment for their low-risk prostate cancer, we obtain an MRI. And if there are any suspicious areas that could suggest higher grade disease, we do what's called an MRI guided biopsy in our Amigo suite. And that's a suite that's really state-of-the-art. Very few places in the country have it. We're one of the few places that we're very fortunate to have it. And what it allows us to do is, under MRI guidance, put the needle right into the suspicious area and ascertain whether or not that area is truly a low-risk prostate cancer or not. I can tell you from our own experience that when we send people with low-risk prostate cancer into the Amigo suite and check to see if they have more aggressive disease, somewhere between 1 in 3 and 1 in 2 times they actually do. And that changes the entire picture, because now these cancers can progress more quickly and treatment is indicated. We've just completed a study looking at the value of multiparametric MRI in telling us who is it with intermediate risk prostate cancer who really has high risk. And this is really an important study because the treatment of intermediate risk requires 2 treatments, usually radiation and a short course of hormonal therapy, a treatment that takes away a man's testosterone temporarily and kills prostate cancer while it's doing that, because testosterone is food for prostate cancer. And it's important because with intermediate risk prostate cancer, you use radiation, 6 months of hormonal therapy, but with high risk, use the same radiation, but 18 to 28 months of hormonal therapy. And there have been large studies that show significant increases in cure rates in high-risk prostate cancer when you use 18 to 28 months versus only 6. Another unique characteristic is that most multidisciplinary teams across the United States, or really around the world, that treat prostate cancer include a urologist, a radiation oncologist, a medical oncologist, and a pathologist. But here, in addition, we have MRI specialists in prostate cancer who do the multiparametric MRI and the MRI guided biopsy. So we have another team player who provides an additional boost to what we can offer men and gets us more towards that personalized approach.